Yep, we're live. Okay, that it worked. Yay.
Awesome.
So hello, everyone. Welcome to tonight's episode of Navigator Nuggets. I am your host, Dr. Nicole Rochester. I am really excited because as you can see, we have a very special guest tonight, Dr. Candice Evans. So I am going to have her introduce herself in just a moment. But tonight's topic is extremely important, and, those of you who are my personal Facebook friends, you know that I posted on my personal page as well, because I really feel that this is a topic that everyone needs to know something about. This is not limited to old people. This is not limited to sick people. And it's not limited to, family caregivers, because the reality is that unfortunately, all of us at some point in our lives are going to, most of us anyway, will face some type of chronic illness that has, reached a point where it may be terminal, or certainly we will have family members in our lives who are dealing with end of life issues. And I just have found throughout my life with my own family members, and certainly in managing clients as a health advocate, and even as a pediatrician, that this topic of hospice care it doesn't come up often enough. It doesn't come up early enough. And there are so many misperceptions about hospice care. So, with that being said, I have a very special guest, Dr. Candice Evans. Dr. Evans is a board certified family medicine physician and a hospice physician, and she is in the Norfolk, Virginia area. And I am thrilled to have her because she is like an expert on hospice. And so we are just going to have a dialogue with you all and really answer your questions. So as always, please feel free to type your questions down in the comment section. I'm going to do my best to keep an eye on those so that Dr. Candice and I can address your questions. And then for those of you who may be watching for the first time, my name is Dr. Nicole Rochester. I'm a board certified pediatrician and a former caregiver to my dad, and the CEO of Your GPS Doc. And that is a health advocacy company where I help family caregivers do three things: relieve overwhelm, reclaim their time, and ensure that their loved ones receive appropriate and effective health care. So every Monday night at 8 o'clock p.m. Eastern Standard Time, right here on this Facebook page, I do Navigator Nuggets. And that's really my way of trying to give back and just give you guys some inside tips and information so that you can effectively navigate the healthcare system for yourself and your loved ones. So Dr. Candice, welcome again. Thank you so much for agreeing
Thank
to be
you.
here. Do you want to add anything, any other, you want to tell us any more about yourself?
Well, you already said that I'm board certified in family medicine, but I've been doing hospice for about 2 years now. I kind of fell into it. I was invited to be medical director by Grace Hospice, and I was already working with a sister company doing primary care. And so they invited me to come on board as medical director, and I just fell in love with it, which when I tell most people that I do hospice, I always get the, oh, wow, that's so
Yeah.
sad. And it obviously dealing with end of life, it's difficult, but I have found it to be so rewarding. And one of the things that is the most rewarding is really educating families and patients about what hospice care is, what we do for our patients and their families, and how great of a benefit it really is. So I am super excited that you invited me, because I do feel like there are a lot of myths surrounding hospice care, and we get called angels of death a lot,
Oh
which is not
gosh.
entirely accurate. So I'm very happy to talk about this very important topic.
Awesome. Thank you. So I guess we should just start with the basics, for people who may be watching who either have never heard of hospice, or maybe they've, like you mentioned, the angel of death, maybe they have that perception. So can you
Mhm.
just explain, to the audience, what is hospice?
Sure. So hospice care, it is a benefit of the Medicare system. that everyone is entitled to. If you are a Medicare beneficiary, you are entitled to hospice care, but it's really end of life care. And end of life is basically defined as when your physician determines that based on your symptoms, your disease course for whatever chronic illnesses you have, are showing signs and symptoms that you may be within the last 6 months of life. And so one of the hardest things as a physician is determining when is the right time for hospice. And that's why I think a lot of people don't always understand exactly what hospice is and when you should elect that benefit. But yeah, so hospice is end of life care. It's multidisciplinary. That's another thing that a lot of people don't know. So as a medical director and as a physician on the team, I oversee the medication orders, the general plan of care for symptom management. But hospice is actually a very, very much a nursing driven field. We have RN case managers who are the bread and butter of hospice. They are in there with the patients. They see them multiple times a week. They are doing wound care. They're doing family education. They're doing medications. So they are really the heart and soul of hospice care. And then we have a psychosocial team. So we also have a chaplain and bereavement coordinator who can help families with their spiritual needs, whatever they may be. And in working on grieving, they can assist the families with pre-bereavement. So the grieving process that starts, say, when you get a terminal diagnosis or when you find out that things are not going to improve. The chaplain / bereavement coordinators are excellent. They're all very well trained. All the ones that I've met and worked with are very well trained in doing that. We also have a social worker who is it's another role that often gets a bad rap. People hear social worker and they think you're going to call APS or CPS,
Yes.
but a hospice social worker actually functions in a bit of a different role. They help the families to navigate some of the more logistical things, paperwork, placement. They can even help with funeral planning, financial things. So that umbrella is a pretty large one when it comes to their role on the hospice team. And then there are aides for like bathing, ADLs, and also volunteers. So it's a team effort by all means. So, I get to kind of sit in the front row and be a part of this amazing team of people who each have a very important role. And I can say honestly that I've not met anyone who does hospice who doesn't absolutely have a passion for it. So,
yeah. I would imagine that. And I think, what you said, I often tell clients that people worry about being abandoned when they go into hospice care. And I often tell clients that this is probably the most coordinated, the most hands-on comprehensive care that your loved one will ever receive.
Absolutely.
And just to recap what Dr. Candice said, for those of you who may be just tuning in, the team includes, and if I miss anything, add it in, Dr. Candice. So Dr. Candice said, so you have the physician, you have nurses, you have case managers or social workers, you have aides, like a chaplain, spiritual care. Did I leave anything out?
Volunteers,
bereavement counseling. So, I mean, you guys know, you all already know how I feel about the healthcare system. Literally, I rag on the healthcare system probably every week. But the reality is that in the traditional healthcare system, care is extremely disjointed. And I wish we had this type of care for patients who are not terminally ill, where you have doctors and the nurses and, spiritual, my hospice care encompasses all of that, the spiritual needs, the emotional needs, and the physical needs of the patient. And I'm glad that you mentioned that, because I just want people, we're going to be dispelling a lot of myths tonight, but that's probably one of the first ones, is this myth that people feel that themselves or their loved ones are going to be abandoned if they choose to go the hospice route. And so that is absolutely not the case.
Right. And like you said, it really is, it is the most care I think I've ever seen any patient get.
Yeah.
In fact, it can be a little overwhelming in the beginning because we've got so many people that are just waiting to, have their turn to help the patient and to offer their services. That sometimes it can be overwhelming in the beginning. But again, the patients are never more checked on, checked in, supplied. we
Yes.
have eyes and ears and hands on our patients almost on a daily basis. So
Wow.
it's really, it's not the time when you're going to be abandoned. It's the time that the patients and families need the most support. So that's what we are happy to provide.
That's wonderful. I wanted to talk a little bit about, you mentioned some of the criteria, or one of one of the big criteria is that, a physician has to feel, and guys, we aren't God and we don't have crystal balls. So this is just
Not
based
at all.
on our medical opinion, based on the clinical data that we have access to. But generally, a doctor has to certify that the patient's condition is life limiting and that their average, their life expectancy is 6 months or less. Is that correct?
That's correct. And for each for each illness that is a hospice qualifying diagnosis, according to Medicare, there are certain criteria that the patients have to meet. So, for instance, one of our most common diagnoses is Alzheimer's dementia.
Mm-hmm.
And so for a patient to qualify, and it's not necessarily that you're qualifying like when you're trying to buy a house and you're qualifying, these are the signs that research has shown support this limited life expectancy. And so we look for functional decline. Is the patient are they still able to walk independently? Are they able to sit up independently? Are they able to eat and drink without incident, without choking? Are they still able to communicate their needs? Are they incontinent of bowel, bladder? Are they requiring more care than they did, say, 3 to 6 months prior? Are they losing weight? Do they have lab values that indicate that they are malnourished despite eating a regular diet? Or are they losing nourishment as they're eating less? And so those are some of the major criteria that we look at that let us know, okay, yes, this patient is exhibiting these signs and symptoms, because they do tend to follow a pattern that they are entering the last 6 months of life. So it's not an arbitrary decision by any means. There are guidelines, there are criteria, and sometimes the patients aren't that straightforward, and we have to look at all of the total picture. So it's not just the physical status of the patient, it's the burden of illness. Do they only have one caregiver? Do they have no caregivers? And the total burden of their illness will actually be a factor in their decline.
Wow.
So there's multiple factors that we look at that affect how we assess and prognosticate the patient. So it's not your doctor is just thinking, oh, you're dying, we're going to put you on hospice. We actually do have to adhere to guidelines. So
that's awesome. That's awesome. We have a question from, we have 2 questions. Marcia says, can you contrast hospice care with home care? So we'll start with that, because I actually was going to ask you about where patients can receive hospice care. So that, I think Marcia's question will kind of lead into that.
So hospice care can actually be wherever the patient calls home. If it's their own private home, that's fine. If they're in a care home, like a private boarding home, if they're in a nursing facility, an assisted living facility, and there are inpatient hospices too, depending on your location.
Mm-hmm.
So it's really anywhere the patient calls home, wherever the patient is comfortable. And we do have patients sometimes that will start off at home, and for many reasons the family feels that and the patient feel that maybe they need more care than the family can provide at home. And so they'll move to an assisted living facility or a skilled nursing facility and continue their hospice care there. So we come into, again, wherever the patient calls home, that's where we're coming in. So
that's really important, because I think another element of hospice care that we probably should address is that, and correct me if I'm wrong, but my understanding is that generally the family member, if you're getting your care in your home environment, you mentioned all the amazing team members, but primarily my understanding is that the family members, the family caregivers are kind of providing the majority of the care, with the other, the nurses and the aides and the other people kind of stepping in periodically. Is that an accurate statement?
That's correct. We really work to educate and empower the family members and or whoever the caregivers are on the best methods to provide that care, whether it's providing the appropriate supplies or equipment. Sometimes the patients need specialized equipment to transfer out of bed into chair, things of that nature, bedside commodes, things like that. And we educate the caregivers and the families and the patients, to the best extent that we can, on how to make sure the patients are getting not only the best care, but the safest care and the care that's going to keep them comfortable. And so we partner with the families and caregivers to allow them to do that. And some families need more support, some need less. It's very patient and family specific. So, we try our best to try to take some of that burden off of the families in an already very difficult time.
Sure. Because I think that's often a barrier. Some family members, it's rough. I mean, you and I are doctors, and, I think it would be very difficult even for me to provide, care in my home for a family member who is, dying. And so I think some family members, they know, they kind of can acknowledge that this probably is the best care for their loved one, but they're afraid that they're going to be like home with their spouse or their mom or their dad or their grandparent or whatever. And then, something acute is going to happen, and they're like afraid that they're not properly prepared to manage that. So it's good to hear that you all do provide some training and some support to the family members. You don't just say like, okay, you're going on hospice now. See ya.
No. It's actually, it's a constant ongoing process of educating the family and the patients, because as symptoms change, as circumstances change, we have to adapt and continue to educate and provide that support as things change.
Awesome. Barbara asked, can you clarify palliative care versus hospice? And so that's another great question. And that ties into another point that I wanted to make, which is that, one of the other requirements to be on hospice care is that the patient, I guess, and or if they're unable to, the family, the power of attorney has to agree to basically defer curative therapy. And this is another area that often, causes some family members and some patients a little prickly. But again, you're not being abandoned, but the whole purpose of hospice is to provide comfort. It's not to just leave you out there to dry, but when you or your loved one has reached that point where, the feeling is that doing more in terms of medical care is not going to make a difference. It's, it's kind of futile. And we have all been in that situation. I'm sure everybody watching has a family member who has had cancer, maybe multiple times, and they've tried all these different rounds of chemotherapy, and we literally watch them wither away before our very eyes. And, the doctor may say, there's really nothing you can do, or, well, we could do another round of chemotherapy or radiation, but the chances are, 5%. So that means there's a 95% chance it's not going to work. But many of us will tend to say, okay, go ahead, do it again. But at the end of the day, we are subjecting our loved ones to trauma, really, is the way I see it, And
Yeah.
I know it's hard. I know we want our loved ones to stay with us forever. Trust me, both of my
Mm-hmm.
parents are deceased. I would love to have
Mm-hmm.
my mom and dad back in my
Yeah.
life. But when you have a family member that is truly suffering, hospice care can really, it's meant to provide comfort, to relieve the
Yes.
symptoms, and they may in fact have a higher quality of life that will
Yes.
allow them to carry out some of the things they want to do as opposed to being sicker from the medical treatments.
Yeah, that's absolutely right. To go back to the original question about palliative care versus hospice care, so palliative care is really that bridge between your chronic with more aggressive interventions and hospice care. So a good example would be you already brought up cancer treatment. So patients often receive palliative chemotherapy or radiation therapy to decrease tumor burden, for instance. So it's not with the idea that this is going to be curative, but it's to try to give the patient a better quality of life. So that would be something that you may receive on palliative care. But then when you make the decision to enter hospice care, it would say that would be the patient saying, okay, no more chemo, no more radiation. I don't want any other aggressive intervention. Another really common disease process that tends to have to go through a palliative transition into hospice is end-stage renal disease and end-stage liver disease. So end-stage renal disease, when people are on dialysis, for example, and they're no longer able to tolerate dialysis. A lot of times as they're transitioning through palliative care and into end-of-life care, they may wean down their dialysis. We have accepted patients into hospice who are still receiving dialysis, which is considered an acute, an aggressive intervention, life-prolonging care. But often the patients will wean down. They'll go from maybe 3 times a week to 2 to 1 to just as needed for symptom relief. And so palliative offers that step between your chronic curative care and end of life care. So, and the other point that you made about patients feeling that, again, this is a time where you're just going to be left to die, that it's really the goal of hospice care, as you stated, is to really bring as much comfort to the patients and to their family as possible. Patients, chronic disease, no matter what chronic disease you have, there is a course of suffering along with it. And so our number one goal is to relieve suffering. We can't relieve death. We can't.
Yeah.
And so, but we can help as best as we can to relieve the suffering. And one of the things that I learned early on in talking with some of the more seasoned hospice doctors in my tenure was that there's a difference between prolonging life and prolonging death. And
There you
so
have it.
that's
That's
something that I try to keep in mind, and that I encourage our case managers, our whole team, to really communicate with the family, because like you said, we want to hold on to our loved ones.
Yeah.
That's just human nature. So then we have to, really talk to the families and say, at what point are we prolonging their death and their suffering as opposed to prolonging their life and our time with them. So
I love that. Prolonging life versus prolonging death. That is so profound. And I think all of us can really, kind of take an internal look at ourselves. And again, it is very difficult, but really, we're being selfish when we force our loved ones to undergo therapy that we know has a very little chance of being curative, and in fact, much greater chance of doing harm, just so that they can, live a few more months, and so, and I'm preaching to the choir, guys, because I'm kind of, I was not always this way. I've grown up, so to speak, with just getting older and seeing family members die, and certainly as a health advocate and having working with families whose loved ones, are facing death. And it gives you another perspective, particularly when you have the opportunity to witness hospice up close and personal. My grandmother had end stage Alzheimer's disease and passed away a few years ago. And she was in an inpatient hospice facility in the area of Virginia. And the care that they provided to her was just phenomenal. I mean, they were just so loving and attentive, and just the environment, when you're in a hospital, I mean, we all know what hospitals are like. It's very cold and sterile. And this was just like, I mean, it was like her bedroom, and they just made her very comfortable. And, there's no visiting hours. So, you can come and go as you please. You can stay there and sleep. And they have like a refrigerator, you can bring your own food. And and they just, they were very attentive, not just to her, but to the family as well, even before she passed away, just making sure that my aunt and, the rest of us, that, we had what we needed. And, so that experience was just really just eye-opening for me. And and then just to clarify, the palliative care, as Dr. Candice was sharing, it's comfort. And I also want to just point out that palliative care does not equal hospice. So, I mean, there are people who receive palliative care for certain conditions, and they are not on hospice or in hospice. You don't have to be in hospice care to receive palliative care, just in case there's any misconceptions about that. Marcia asked, are there enough hospice facility beds for those with no support system or family? That's a good question. I know the answer to that, but I'm gonna let you answer, Dr. Candice.
Unfortunately, the answer is no. There just aren't. And it's definitely, especially as the population is aging in general, we're living longer with diseases that used to kill us early and quickly. But now you have chronic patients. I mean, I think I just read that the oldest living HIV patient just turned something close, like 90, somewhere between 90 and 100.
What?
So these, there's illnesses that for the longest time, you wouldn't expect anybody to last having them. And so, and again, with the population in general aging, we don't have the resources that we really need. And, that's something that, however you're moved to help, that's a great thing to donate your time, support, money to, especially I think a part of it, and what I've learned doing this, a part of it is that the healthcare system in general and medicine in general, we don't do well with death.
No.
And as physicians, especially, death is the ultimate enemy. It is.
Yeah, it's like a
you're
failure.
Out to defeat it, right?
Yes.
So we feel like if our patients are dying, then if we admit that our patients are dying, that means that we're admitting that we have failed. And that's not the case. It's not the case. And so the conversations aren't had where they need to be had. And so the funding doesn't get put where it needs to be put in order for us to have these necessary facilities. So the long answer and short answer is no.
Yeah.
But that's, it's always something that, that should be a part of the conversation overall for healthcare, especially in America. So
absolutely, like you said, because we are, living longer, and we're living with these chronic diseases much longer. And, that is a huge problem, with not having facilities, so that if you don't have a family member who can, literally kind of, I mean, if you work or have another, kids, you really have to kind of put that to the side if you are going to be the primary caregiver for someone in hospice, or you have to be able to afford to pay, your own personal caregiver, whether it's a home health aide or whatever, to take care of that loved one. And unfortunately, not everyone has those kind of resources, and not everyone can just kind of pick up and take a leave of absence from their job. And so then we have patients who would be wonderful candidates for hospice, but there's no inpatient facility and there's nobody that
Mhm.
can really do it in the home. So they just are kind of
Yes.
stuck.
Yes. It is something. Our social worker, she is amazing, and that is the number one project for her, for
Yeah.
just about all of our patients at some point or another, trying to find placement, whether it's for respite care or for long-term placement.
Yeah.
It is a challenge. So
Deneen asks, she says, hospice care is a great option for many patients and their families, but when you look at some of the data from CMS, there are differences between the quality of care at different hospice providers. That's absolutely true. So she wants you,
that
Dr.
is
Candice,
true.
to weigh in. How can patients select the best hospice provider?
Word of mouth,
Mhm.
honestly, because it, the squeaky wheel gets the attention, right? So unfortunately, and we learned this as physicians just in general with patient reviews and press Ganey scores,
Yeah,
and the ones that are going to speak out are people who have not necessarily had the best experience. And so, anything reporting that you find online, the data tends to be skewed in the negative direction because those are the people that are going to, speak up and say things. Not saying that those poor experiences don't exist, because they
sure.
absolutely do.
Yeah.
But I would say word of mouth, honestly, that has been our number one referral source. Patient families come to us and say, you guys took such great care of mom that, when it's dad's time, we're going to come back to you. We have
Wow.
husbands and wives. We've had, parents and children who have used our services. And so those referrals are the most meaningful ones. So honestly, if you have a friend or another family member who has received hospice services, ask them what their experience was and would they
Mhm.
recommend that hospice, honestly,
Yeah.
because that really is the best way, because those are the people who really know the kind of care that they're going to get with that company.
Absolutely. And that's the same advice that I give for, any medical provider. We
Mm-hmm.
talked about this on Navigator Nuggets. If you're trying to choose
Yeah.
a primary care doctor, or if you're trying to decide, what hospital to have an elective procedure or to deliver your
Oh,
baby, or,
absolutely.
always ask, there's nothing like that firsthand experience, like that word of mouth referral from someone that you trust. And you
Right.
could also hire someone like me, shameless plug. But honestly, I mean,
Yeah.
this is a lot. These are times when, obviously when you're dealing with the death or impending death of a loved one, is very stressful.
Mm-hmm.
And, this is a perfect situation to consider hiring a professional health advocate to really
Yes.
kind of help you navigate the system. And, that's one of the services that I provide. And I will share with you all, for those of you who won't work with me or another health advocate, that you can get objective data online on
Mm-hmm.
Medicare.gov. So just like Medicare.gov has a nursing home rating site, they also have one for hospice. And I'll type it
Yes.
in the comments, but it's Medicare.gov/hospice compare. And that's one of the many resources that I use when I'm working with clients and trying to help them vet hospice facilities. And so there, you can type in your zip code or the zip code where your family member lives, and you can see some objective data, some of the quality
Mm-hmm.
measures that CMS, which is the Center for Medicaid Services, they have.
One of those.
I always get it mixed up, but they have criteria and quality measures that they have established to
Yeah.
evaluate hospice facilities. And it allows you to, you could choose 3 or 4, maybe up to 3, and line them up. And you can look
Mm-hmm.
at them side by side and see, some of the quality data. You can see some of the concerns.
Oh, yeah.
So I
And they
definitely,
are rigorous.
yeah. And like
They
Denise
are
said,
thorough.
yeah, very, very thorough. Very, very thorough. Let's see. I thought I saw another question. Let me see. Okay. No, maybe not. Okay. So the other thing I wanted to talk about is, what about if people change their minds? So, well, actually, before I ask you that, let me address this. So one of the other myths with hospice care is that you can't get care for anything. Like once you go on hospice,
Yeah.
you can't go to the hospital, you can't go see any other doctor, you can't, go to the emergency room. So let's just address that misconception, because the
Right.
reality is that when you go under hospice, you are going under hospice care for a particular condition. And yes, you
Right.
may have 6 other medical conditions that still require active management. So can you just talk
Right.
about that a little bit, Dr. Candice?
So yes, that is definitely one of the biggest fears that our patients and their families express when we're talking about admitting them to hospice is, well, that means I can't go to the hospital, or that means if I have a UTI, I won't get an antibiotic.
Yes.
And that's absolutely not the case. Let me just say that that's not the case at all. When it comes to your hospice admitting diagnosis, yes, it's an agreement that you have told us that you don't want any more aggressive curative interventions and you want to be kept comfortable. That doesn't mean that other things aren't going to come up. We did recently have a patient who, obviously I can't go into detail of HIPAA, but we did recently have a patient who's on service with us who had an acute event and went to the hospital, was actually admitted, stabilized, and then came back home still with hospice care because the hospital admission was not related to the patient's actual hospice diagnosis.
Yes.
But it was serious enough that the patient required acute inpatient treatment. And that's something that we were able to work out. And it doesn't affect the level of care, doesn't affect that patient's still receiving their hospice benefit. So that is something that is still, and again, it's really about communication with your primary care provider, the hospice physician, the hospice team. We all try to work together in the best interest of the patient. So my advice to anyone who was thinking about, or who, their loved one may be going on hospice, if that hospice comes in and they say, oh, we're going to stop all of their medications, run the other way.
Yes, that is not your hospice
provider. Right. That's not an appropriate approach to care. And I think because that does happen sometimes, that's where patients and families get this idea that, well, once I'm on hospice, I can't get treatment for anything else. And it's just not the case.
Yeah, thank you for clarifying that, because there may be something acute that comes up that if that's not treated, it will hasten your death. Right. And that's not our goal. Like, we're not trying to have you hurry up and die.
Right.
So, if you go on hospice for, maybe you have a metastatic cancer and there's really nothing else that can be done. But like Dr. Candice gave as an example, you develop a urinary tract infection. Well, if that's not treated, that infection can get into your bloodstream and cause sepsis. Right. And then, but nobody's going to say, oh, well, she's dying anyway, so we're just going to let that urinary infection spread. Like, no, please.
No, we still do very aggressive wound care. Bed sores are unfortunately a very common issue with patients as they become bedbound and as they lose their nutrition. We deal with a lot of pressure ulcers, but the nurses, they are on top of them, and we can't always get them healed, obviously. Yes. But we do our best. So again, it's not that we say, oh, well, you can just sit there and fester because you're dying anyway. But so no, because number one, we know that's not comfortable, and our number one goal is comfort. So why would you let your patient experience something that's treatable and or preventable that's going to make them uncomfortable? It just goes against the whole philosophy. So
awesome. So let's talk about getting off hospice. So, of course, the majority of people who are on hospice do ultimately pass away. But there are some people who actually get better. So actually, Ethel, one of my loyal Navigator Nuggets viewers, she said that she received hospice back in 1992. She said they were fabulous. They helped me get help to stay at home with my small children. Thankfully, I made a great recovery. So, I think I was reading somewhere around, is it like 10 to 15% of patients, I don't know how that number may not be accurate, may actually come off of hospice. So for example, you could have someone who has a terminal cancer. I keep using cancer as an example, but then maybe they go into remission. And so then they come off of hospice. So I get, getting better is one way to come off of hospice. And then also I think some patients and family members may just decide for whatever reason, like this wasn't the right option. So can you address both of those?
Yes. So that's true. So in some cases, I would say in my experience, I think it's been maybe less than 10% of our admitted patients, when patients are appropriately admitted, maybe less than 10% actually go into some form of remission or plateau. But that is one. So with hospice, it's not a once you're on. We review the cases every 10 to 12 weeks to recertify. So the patients we go through all of the disease criteria again. We look at what their course has been during that particular certification period, and we note if they're having decline or not. And so that's, for one thing, it's a way not to waste resources, but it's to make sure that the patients are still appropriate for hospice care. It's a chance to review their entire course, see if there are any major changes that need to be made to the plan of care. And so that's one way that we have, they're called live discharges. So one live discharge is if, like you said, if the patient just kind of gets better or if they're no longer declining. And that's the one that can be fairly tricky. It's pretty obvious when somebody is getting better. It's not as obvious when someone hits a plateau. We see that a lot with dementia patients, with patients who have had a stroke and who initially had a really, really sharp decline, but then they kind of hit a plateau and they're still not functionally where they were prior to the event, but they're no longer actively declining. And so that is when kind of the art of medicine and the really having to be able to evaluate really, really closely how the patient's doing, because those are the trickiest, but those are the ones that tend to come up for live discharge. And then, like you said, sometimes patients revoke, families revoke. They say, we're not ready for this, and that's their right. That's absolutely their right every time. Or they may say, well, we want to go and try this potential curative treatment one more time. And we say, that's great. When you're ready, if you ever become ready, you can always come back. So it's not that if you elect to revoke your benefit, you can't come back. That's it. You used it up. No, you can always be readmitted when it's appropriate. So that is definitely another thing that I think families and patients get scared of, because they think that, what if I change my mind and they're not going to let me off and now I have to die?
Gosh.
It's not. I mean, I've heard it.
I'm sure you have heard it all.
I've heard it, and again, we try to, as far as acceptance and the grieving process, everybody does it differently. We meet the patients and the families where they are in that process. We don't try to rush them along or hurry them along to acceptance. We meet them where they are, and at the same time try to make sure that we're being honest with them and setting realistic expectations. So
that's wonderful. I appreciate that. Can you discuss how, so Vicki says it's a great reason to keep your PCP as opposed to using the hospice medical director as the PCP. So she's saying some, and Dr. Candice is a hospice medical director, so but she said some hospice medical directors do not treat infections and do stop all meds. So I guess that leads me into the question of how does the hospice team work with the patient's own primary care physician?
So it's very physician dependent. And it depends on the patient's preference. So I have several patients who I actually work with their PCP in the same practice on the primary care side. So I'm in very close contact with them on a regular basis, and they'll call me and say, hey, what's going on with this patient? And then I have other patients for instance, the patients who are in facilities where they have a facility physician who they may not even have that close of a relationship with.
Yeah.
And we'll send them their care plan, and they'll let us know if there are any questions, and we'll try to answer them. So it's really, how comfortable is your physician with managing a patient who's at the end of life? And how comfortable is your medical director with collaborating with that physician? And really, all of the medical directors should be. That's an excellent criteria. That's an excellent question to ask when you are interviewing hospice companies. You know, how well or how closely does your medical director work with the patient's PCP if they elect to continue with their care? So, you know, I try to be as available to the PCPs. I often have questions for them, and I'll, you know, put in calls or have the nurses try to stop them when they see them at the facilities and say, hey, Dr. Evans wants you to give her a call because she has a question about this. And so, because it can't be a unilateral decision, you know, decision making. It has to be collaborative. It has to be a team effort for the best interest of the patient.
And I think, you know, just like anything else, families tend to feel more comfortable when the doctor who has known their loved one for years, who has taken care of their loved one for years, is still involved. But you brought up a really good point. Not all doctors are going to be comfortable with this, you all. So, you know, you or your loved one may have a doctor who, you know, this isn't really in their wheelhouse. They don't really understand hospice. Because let me tell you, a lot of doctors
don't learn about it
they don't teach
much
us
as we should
in medical school. I don't think I got a single lecture. Now maybe things have changed. I'm a little old. Dr. Candice is younger than I am, but I didn't get a single lecture that I remember about hospice. And definitely, I mean, we definitely learned about end of life, like in general, but not like how it works, like how the system actually works. And so your loved one's physician may not even really be comfortable or capable, to be honest, to manage your loved one while they're in hospice. So I guess you know, you really have to ask the questions and really try to figure out, you know, which is the more qualified person, which one, and but you can keep both, right? I mean, you can keep the primary care doctor and work with the hospice physician.
Absolutely. So, and that's what a lot of, even the ones that I work very closely with, they still get regular visits by their PCPs.
Wonderful.
And they still manage all of their chronic issues. And the things that I'm managing are the hospice diagnosis related issues, pain medicine, symptom management. Those are the things, you know, directing nursing orders for, like I said, wound care or acute issues that come up. So I'll do that, but then the PCP is still managing like their diabetes or whatever else they might have. So it really is a collaborative effort, and it has to be a collaboration on both sides, honestly.
Yes, absolutely. All right. Well, it is 8:48. Let me see if you guys, if you have any.
I wanted to, if I can.
Oh, please. Yes. yes.
One thing that when we talk about hospice myths, and I'm surprised that the question hasn't come up, but the biggest challenge that we tend to have is with medications and end of life, specifically morphine.
Oh gosh, yes, we have to talk about this.
That's a whole other, I mean, that could be its own session in itself. But there's a really, and if my administrator gets wind of this, she is going to hang me by my toenails, that I can't remember who the author is, but there's a really good piece called Fear of the Last Dose. And it talks about how, if I find it, I'll send you the link so you can
Fear of the Last Dose?
Fear of the Last Dose.
Okay.
So, and it talks about how family members are terrified of the use of opioids, specifically morphine, in final days, hours, minutes of life. And the opioid crisis has not helped this fear at all.
I bet.
I mean, it has made it 10 times worse. So the thing, without going deeply into all the pharmacology and whatnot, what I always tell my patients and their families is that you are not going to kill your loved one with morphine. The disease process, whatever it is that they're admitted for, that is the culprit.
Yeah.
What the morphine does is it helps with respiratory comfort. One of the biggest things that I think, if we all were to list out our biggest fears about dying alone,
Yep.
and also
And
dying in respiratory distress.
Yes.
Feeling like you're suffocating, feeling like you can't get enough air. That, because that's how it's dramatically portrayed in movies and on TV. And so that is the worst possible death you could think of for most of us, and 10 times worse to watch our loved one go through that and know that you can't do anything about it. But actually we can. That is what the morphine is helpful for. It helps to relax the smooth muscles in the lungs so that there's better, more efficient air exchange, so that the patients don't feel air hunger. Yes. And so that gasping breathing that is so hard to watch, that's what it helps with. And everybody's scared that, morphine is going to slow their breathing down, it's going to make them stop breathing. Well, we want it to slow their breathing down because they're working hard to breathe, because they're not able to exchange that air efficiently. And so that is one of the things that we educate our families on from the beginning. And not everybody ends up needing it. And that's another thing. Like I said, if your hospice automatically comes in and brings all the comfort meds and, overwhelms you with, here's the morphine, here's the Ativan, here's the atropine, and it's a lot. So one of the things that I personally prefer to do is to wait until the patient is showing symptoms that they're going to need those particular medications, and then making sure that the nurses go in and do a really thorough teaching session with the families. If they need me to call them and explain further in more detail, I'll do that, because again, end of the day, our goal is for the patients to be comfortable, and we have tools, we have certain medications that can really make a difference in those final minutes, hours, days of life, so that as they're transitioning, there's less stress on their physical body, but then also less trauma to the family. And so if nobody takes anything else home from this, please, just ask questions, but be open-minded about and understand that the way that we use medications and the way that we use certain resources in hospice is very different from how, your everyday PCP or your pain management doctor or your ortho doctor is going to, prescribe these medications.
That is such a good point. Thank you for not allowing me to end this broadcast because without addressing that. Raina says, my question is, how does a family member decide on a medication that will help their loved one in their last hours? And I think you addressed that. It sounds like morphine is definitely the mainstay. You mentioned other medications, like I heard you say atropine.
Yes.
Are there benzodiazepines? Or
yes. So we tend to use lorazepam, which is a kind of a medium acting benzodiazepine, and that helps with agitation. Terminal agitation is what we call it, when patients are just restless as their bodies are transitioning. Atropine, you'll hear about, or sometimes, of course, my memory is failing me right this second. But atropine, we use it for secretion. So a lot of times people hear about that death rattle, gurgling. It's because the patients just aren't able to control their natural secretions. And so medications like atropine can help to cut some of that down. Again, for comfort, there are nausea medicines and medications for delirium. And so we never just leave the family out there to guess and say, I think they need this medication. When we determine that patients are imminent, that they are actually transitioning and dying, the nurses are always on call 24 hours. I'm on call 24 hours a day, every single day, for them to call me. Yes, for them to call me But the nurses, are that's when they're making daily visits with the patient and the family. They're assessing the symptoms. They're saying, okay, when you see this symptom, you can give them this much, this often. So it is very, very thorough education, and we don't leave any guesswork to be done. So
great. Awesome. Okay, I'm going to do one last scroll. For those of you who are live, this is your last chance to ask Dr. Candice Evans or myself any questions. And then, as you all know, I always come back and watch the replay and check in on your comments. So if you have other questions, or for those of you who are going to catch this on the replay, please feel free to type your comments. And Dr. Evans and I will do our best to kind of keep an eye on that. Let me see if there's anything else. Oh, sure, Raina, you are very, very welcome. All right, so I think that's it. So guys, I know this one lasted a little long, but when we have guests of this caliber and we're talking about a topic that is so big, like Dr. Candice said, I mean, we could have a whole session just on medications.
Absolutely.
But I thank you to all of you who tuned in. I know that this is a difficult topic. None of us like to talk about death, even those of us who are physicians. We know that this is difficult, but honestly, hospice care can be one of the best gifts that you can give to your loved one, who is terminally ill. And, when they're in that situation where doing additional aggressive therapy is really going to be of no benefit. And so I just really wanted you all to hear it, to get your questions answered by an expert, and to really just have a better understanding, so that the next time the word hospice comes up, I'm hoping that instead of you all immediately, going into defense mode and getting angry or getting scared or sad, that, come back and watch this video. Please share this with your friends, your family members, your colleagues, your church members. Everybody needs this information. So I'm going to rely on you all to share this video with your friends and family members, and just let them know that they need to watch this so that they can get a new perspective and really be educated about hospice. So Dr. Candice, I cannot thank you enough. This has been amazing.
Thank you.
I have learned a lot. I thought I already knew a lot, but I learned even more. And so I really, really appreciate you spending time with us tonight. How can my viewers find you if they want more information? Is there a website, or are you on social media?
I am on social media. I'm working on my actual official Dr. Hospice patient. Page. So that is forthcoming. But I am on Facebook, Candice Evans. You can find me. But yeah, I can forward it to you when I have my official.
That would be great. And what I'll do is I'll go back into this video and add it as a comment. Or I'll put it in the description. That'd be awesome.
Yeah. I'm still working on it, trying to, figure out how I want it to go. But like you said, I mean, thank you so much, first of all, for having me. This is an important topic. And as you can tell, it's something I'm super passionate about. So I am happy to be a resource, for all of your viewers and listeners. So yeah.
Awesome. Thank you. All right, guys, have a great night. I'll see you next Monday. Take care.